Okay, so over the next 15 minutes or so, I'm going to talk to you about a technology that a lot of you are not using. That's whole body MRI and its role in metastatic disease, but realizing that the context here is personalized oncology. These are my disclosures. You'll see that I'll be talking about the off-label use of the equipment and software and perhaps of drugs, because I don't know all the indications of all the drugs that are being used, that whether they're off-label or not. So if we think about personalized medicine, we think about the right treatment for the right patient at the right time, but we forget it's for the right duration. And the choice of drug depends on what we're now calling next-generation diagnostics, which also includes imaging, but also other things such as immunohistochemistry, tumor markers, etc., etc. Now, so here's an example of molecular pathology-directed treatments for advanced prostate cancer. So we look at the cell type, we look at immune infiltrates, you look at AR signaling, DNA defects, repairs, etc., and then you decide on a therapy. Now, once you decide on a therapy, then you develop some sort of idea about tumor viability, and you repeat that at those assessments over time as patients get treatments, and then you assess how patients are progressing along the treatments, and at progression you switch treatments to a second treatment, to a third treatment, etc., etc. And you want to get those treatments in at the right time so that patients don't progress too much as they move along their journeys, so that we keep the tumor burden as low as possible for as long as possible. Okay. So if you think about that context, then we have to ask the next question: how good are we at the moment? Are the current tools fit for purpose in this precision medicine era in metastatic bone disease? And I would contest that, in fact, we're not very good at all. So the current techniques have a number of limitations. The first of these limitations is that we are unable to tell you oftentimes when people have metastatic bone disease. So using CT and bone scans, when we say to you the patient does not have metastatic disease, we are unsure in a substantial number of patients. When we say to you patient has oligometastatic disease, in fact, quite a few of these patients have polymetastatic disease. And the volume of disease really does matter in terms of treatment prescriptions, as most of you will be aware. So, for example, if you have high volumes of disease in metastatic prostate cancer and you are castrate naive, you know that you benefit by adding docetaxel to an ADT treatment. Whereas if you have a small volume disease, then 5 minutes. So you have 5 minutes to do something else if you want. Okay, so if you have small volume disease, then the addition of a chemotherapy to ADT may not be there. And this is some data that was published in 2015. So volume of disease matters. The other problem is that the technologies that we use currently don't allow us to detect progression in a timely fashion, which means that you wait too long before you switch a therapy and patients' tumor volumes can increase substantially. And I'll show you a couple of examples. So here's a patient, and here's a whole body MRI scan. We'll talk about this technology in a minute, but you can see this patient's getting enzalutamide. He has a raised PSA, retroperitoneal lymph nodes, bone scan negative. Receives enzalutamide, 12 weeks later, PSA suppressed, a bone scan is negative. You can see on the whole body MRI scan that the lymph nodes are getting smaller, so everybody's happy. After 24 weeks of treatment, we see a new lesion in the retroperitoneum, in a bone. And how do we know that this is a metastasis? Well, we have 2 scans beforehand, and we can focus in on other sequences, which I don't have time to show you, to show this is an unequivocal new lesion, therefore progression. The problem is, and here is the slide I wasn't going to show you, where we can focus in and show that this is an unequivocal new lesion. Okay, now, of course, the standard of care is the bone scan, and the PSA is suppressed. So a lot of you will continue to treat because you don't trust this new technology. Again and again, the PSA is suppressed. but the bone scan does show 2 new lesions. Is this progression? The answer to that is not yet, because the emergence of 2 new lesions needs to be confirmed in the context of a clinical trial before you can say that this patient is progressing. So another 12 weeks goes by, and then you see polymetastatic disease. So if you think about what just happened, oligometastatic disease at week 25, polymetastatic disease confirmation, right, at week 50, right? So 25 weeks of treatment that this patient did not need, right? And the tumor volume probably increased 300%, 400%, 500%, right? While you were doing nothing except giving a drug that wasn't working. You guys often use CT scans, and you think that's going to be good enough to compensate for what I've just shown you. And the problem is it doesn't compensate. You think it does, but it doesn't. Okay? So let me show you an example. So what are the problems as far as the bones are concerned? Well, progression can occur, and you don't even realize it. Let me just show you an example. So here's a patient who comes with metastatic ER-positive breast cancer. You can see the patient has, on this whole body MRI scan, you can see these lesions. These are metastatic deposits. The patient has got mild symptoms. The CT scan is negative. Okay? So she gets treated with what you'd expect, an aromatase inhibitor and zalendronate. And then she goes on to standard of care, which is what? CT scans, right? And tumor markers, which we don't work. And so she goes and has a CT scan next time. CT scan is read as stable, so everybody's apparently happy, right? And then she comes back, and now she has moderate bone pain. Moderate bone pain, and then she comes back, and this is what's happened. So you've got marked disease progression, and you can see the CT scan at this point is showing mild disease progression. Now, the MRI scan confirms that there is polymetastatic disease progression. And if you measure the tumor volume went from 53 cc's to 473 ml of tumor. And 1 order magnitude of difference, right, in the amount of disease this patient has. Okay, so what's the problem? The problem is standard of care CT, because this CT was completely non-informative, right? So you have no idea what happened to this patient between time point 1 and time point 3. In fact, there was a lost opportunity. You don't know whether the patient progressed, whether the patient was stable, then progressed, or the patient benefited, then progression. You have no clue what has been going on for month after month after month, right? You just have no idea. I have no idea. So this represents a loss of an opportunity for this particular patient. Now, the other problem is that there is something called sclerotic progression and sclerotic response, both of which occur. Now, this is a classical example of sclerotic progression. So this is a patient who is receiving a PARP inhibitor, and you can see, if you look at the bones, you can see areas of fluffy sclerosis appearing in the bone marrow. This is progression. And every radiologist will call this progression. So it seems to work, right? The problem is this. This is the same patient, after progression, gets treated with carboplatin. Now, if you look at these scans, and this is the same patient as I said, you'll see that the lesions become more conspicuous, and you see new lesions. So, for example, that lesion there was not there before. Is this progression? The answer is no. This is response. So you have new lesions that are sharply marginated, but appear, and sometimes a lot of radiologists will call this progression, but it's not, it's response. So, bottom line, sclerotic progression and sclerotic response both occur, and that is a problem. So the question is, let's try something different, because this stuff obviously doesn't work very well. Now, does whole body MRI help you in this? Now, what is the advantage of whole body MRI? One of the advantages is it's something that looks like a PET scan, but You know, it's not a PET scan. This is looking at cellularity and cellular viability in the skeleton. And the other thing is, a policeman can read this, right? They can look at that and say what is cancer and what is not cancer, right? So the policeman can do this, you guys can do it also. The other thing is, there is a standardized technique. It's published, the standards are published, so every one of your radiologists can do this. And remember, this has been done on a scanner that's 7 years old. 7 years old. So, you know, this equipment is available to you in your clinics today. It's not very new stuff. Okay. And how good is it compared to bone scans and CT scans for detecting metastatic disease? The answer is pretty good, right? So here is standard of care CT scans, high specificity, not great sensitivity on a CT. Bone scan is all over the place, very 1970s. Probably shouldn't be using it in the 21st century, right? PET scans here, FDG PET scans, and here's whole body MRI scans. So think about moving forward, now they're in the 21st century, okay? The other advantage is the changes you see, such as this patient who's receiving docetaxel, reflect cellular viability. Are the cells alive or are the cells dead? Okay? Now, the thing is, you can color code these cells, whether they're alive or dead, according to using a traffic light system. So my clinicians like red to be bad, green to be good, and yellow to be somewhere in between. Yeah? So all of us understand traffic light systems, okay, hopefully. So you can see this patient at the start is red, all bad, lots of active cancer. This is post-docetaxel. Most of it is green, good amount of cell kill, bits of red still around, so still you need to give more therapy after 4 cycles of docetaxel. Now, what I wanted to do was demonstrate the utility of this in a personalized medicine setting. So let me just show you a patient. So here's a patient who presents 6 years after a node-positive breast cancer. She's HER2 positive. And over the next 4 to 5 years receives a number of lines of anti-cancer therapy. Okay, so we pick her up in 2012. Now, all I want you to do is look at the colors, right? Don't look at anything else except the color. Now, what color do you see? Red. Red means bad. How much bad is there? 95%. So, look how much color there is and how much there is, right? So, 95% of the tumor is bad. So, she gets initially treated with exemestane and Herceptin, and a few months later, so, oh, by the way, we give radiotherapy to the right hip. Now, I want you to watch that right hip over the next few slides. Okay. Now, so we give her exemestane and Herceptin, and you see she's still red. Bits of yellow have come, but basically not much has changed. Okay? But you'll notice she's developed a liver metastasis. So we changed treatment to pertuzumab, Herceptin, and a taxane. Now what happened? The red is gone, right? What do you see? Greens and yellows, right? And if you look at the amount of volume non-responding, it's gone from 90% to 50%. So this is a response, okay? Now, look what happens on the next occasion. On the next occasion, we begin to see the red coming back in various parts of the body, but look at the right hip. What's happened in the right hip? Remember, this is where we gave radiotherapy, right? So this is an area of treatment resistance. Why? Because you gave it radiotherapy some months ago, right? So this is spatial discordance, okay? So what happens next? Oh, more red, right? Things are not good, okay? And then look what happens next. It's all red. So she's back to her original status. Time to switch the therapy. So let's switch her to chemo. Oh my God, what happened now, right? Completely green. She's had a fabulous response. Only 25% of the tumor is now in what we would call the viable range. Give her more chemo. Wow, look at that. 3% viable tumor. Okay. Carry on. we begin to see little dots of red beginning to emerge. But she's still doing pretty well, okay? Next occasion, more areas of red are beginning to emerge. So treatment resistance is occurring. You can see it in front of your eyes, and on the next occasion, lots and lots of red. So this is classical therapy, secondary therapy resistance, okay? And on the last occasion, so we switch our therapy. This time we give a TDM1 or Kadcyla. Now, look what happens with Kadcyla. Only the right hip responds. Why? Because this is where you gave radiotherapy 3 years ago. You have altered the microenvironment of that right hip 3 years ago with 1 fraction of 8 gray of radiotherapy given for a palliative setting, and it is behaving very differently, very, very differently. Okay? And on the next occasion, look what happens. Red. Okay? Give her more Kadcyla, more red. If it's not going to respond, it's not going to respond. So then we give her vinorelbine, and we know vinorelbine doesn't work. I've never seen a response. I think we've seen one response in the last 2 years with vinorelbine. So it stays red, and now she's on weekly epirubicin and got lots of liver disease. So let's try to summarize what we've just seen. You have metastatic bone disease. You have all these targeted therapies. At the moment, what are you doing? Response? Non-response? No. At the moment, you're doing progression, no progression. That's what you're doing. This is what happens in the clinic. What I'm suggesting is that with these next-generation diagnostics, right, which includes imaging, but all kinds of other stuff, you actually break that categorization into 3. So you've gone from progression, no progression, to response, stable, and progression. In other words, this is exactly what you do for soft tissues, but you can now do it for the bone marrow. And that changes the way you think, and that changes the way you practice precision oncology. So, here's my conclusion. I think you should really be thinking about moving away from bone scans. It's about time, okay? We know that whole body MRI is already in clinical practice. It's in the recommendations already for multiple myeloma. The guidelines have already been published on the imaging standards. That has now been published. So you can't say, I don't know how to do this, or my radiologist doesn't know how to do it. The recipe is in the guidelines. There's a real potential here for you to think differently about your patients, because you switch progression, no progression, to response, stable, and progression. Now the question is, will patients live better for longer? Now, so you're asking me how well your drugs will work if you use my technology. And again, this is a circular argument, because you keep on changing your treatments. How can you test that? It's very difficult for me to test that, but we need to think about how we do that. I think there's a potential here to put forward precision medicine for patients with metastatic bone disease, which of course is the right treatment for the right patient at the right time, but what imaging lets you do is for the right duration. Thank you very much.